Good evening. I'm Lisa Burke from the Department of Rural Health, and I'd like to begin by acknowledging the traditional owners of the lands which this webinar is recorded from and streamed to. I acknowledge elders past and present from these lands whose cultures and customs have nurtured and continue to nurture these lands. And I also acknowledge all First Nations people joining us this evening. Myself, I'm here on beautiful Yorta Yorta country on the banks of the Goulburn River, and I feel very privileged to live and work on this country. Just so you're aware, you might like to have your computer set to speaker view, and you can do this in the top right-hand corner. There will be an opportunity to ask questions through the Q&A icon at the bottom of your screen, and we'll attempt to get through as many of these questions as possible after the lecture. But tonight's webinar is brought to you by the Department of Rural Health at the University of Melbourne, and we're delighted to bring you this webinar by Professor Flavia Cicuttini. Flavia is Professor and Head of Rheumatology at the Alfred Hospital and the Musculoskeletal Unit at Monash University. Flavia is also a National Health and Medical Research Council Leadership Fellow and serves on the Council of the Australian Academy of Health and Medical Sciences, the Australian Institute of Health and Welfare National Arthritis and Musculoskeletal Monitoring Advisory Group, the Repatriation Medical Authority, and the board of the Osteoarthritis Research Society International. So she's very busy. Flavia is passionate about providing quality healthcare to rural and urban communities, and is looking at innovative ways to reach people to assist them with evidence-based healthcare. So please welcome Professor Flavia Cicuttini to talk to us on patient-centred care for osteoarthritis, gout, and other musculoskeletal diseases. Thanks, Flavia.
Thank you very much. You can see my screen?
Yeah.
Good. So thank you very much today. These are my disclosures, and also I'd like to acknowledge the traditional owners of the lands on which we're meeting today as well. Thank you. So the aim of today's talk is to consider some common musculoskeletal conditions and to look at consider new evidence, challenge some of our current approaches, and discuss management options based on trying to get a bit of a more of a patient focus and an evidence-based approach. So the plan today is to look at what's new in osteoarthritis, and so look at obesity, exercise, consider the idea that osteoarthritis isn't just a single disease, think about joint replacements, and also remind ourselves that osteoarthritis is actually associated with increasing death rates. And in the second part, I'd like to turn to gout and really the new thinking of this treat to target approach. So to start off, we all know that osteoarthritis can affect virtually all the joints of the body, and the common risk factors are we inherit a tendency to have osteoarthritis. It gets more as we get older. Many of the joints have more osteoarthritis in women rather than men. Obesity is one of the major risk factors, but also trauma and injury and physical inactivity. Now, what I'd like to do is just have a think a bit about obesity. So it's key modifiable risk factor. We've known forever that it's associated with lower limb arthritis, knee and hips, and so on. But it is also a risk factor for hand osteoarthritis. So given we don't walk on our hands, it can't just simply be loading. Now, we know there's a lot of interest in weight, but also we know that people of the same weight can have a very different composition. One person can weigh the same but carry much more fat compared to another person's muscle. And from a lot of studies now, we know that one of the things that really is associated with joint damage is actually the fat you carry. It's associated with loss of cartilage, there's different damage to the joint, and also joint replacement. Now, obesity is a complex syndrome. So it's not just like carrying a 20 kilo of sack of concrete, which is an inert substance. Fat itself is a living organ that produces a lot of inflammatory and metabolic abnormalities. And so, and these play a role in a lot of chronic diseases, but also in osteoarthritis. So you could argue that obesity causes a double whammy on joints, where not only do you have loading, but you're loading what is effectively a slightly squishy joint. Now, obesity, also affects joints across the life course. So you start off with normal joints and slowly you start to get early damage, then the disease, osteoarthritis, and finally end-stage joints. And systemic, or these inflammatory factors, are very important in the early stages. And of course, once you get enough damage, it becomes more and more just a mechanical problem. Now, the World Health Organization has reminded us repeatedly that if we are to tackle obesity, we should be looking at preventing weight gain. We should be looking at people maintaining their weight. And weight loss is important, of course, once you're overweight or obese. But these other areas are also important. And so we looked at the international clinical trials recommendations, and all trial recommendations recommend weight loss. Only one recommended maintaining weight, but this was after they recommended weight loss and then maintain the loss you've got. And no one talks about prevention of weight gain. And this is not very different to recommendations you'll see for other chronic diseases as well. Now, what's been quite disturbing is that when recently people are starting to publish meta-analysis or systematic reviews where you get the data from lots and lots and lots of studies, and we're now constantly seeing that the effect of weight loss in, for example, knee osteoarthritis, where it's most studies, isn't really super impressive. And so, for example, loss of 5 to 10% of body weight will result in a reduction in knee pain of a similar size to Panadol, where no one's very impressed with how effective Panadol is. Now you can say, well, why is that? And that is because what tends to happen is that as you chuff along through your life, you gradually damage joints. And then once people have a condition like osteoarthritis or diabetes or heart disease, we set off and try and get people to lose weight and all the rest. And the weight loss is important. I'm not for 1 minute really saying we shouldn't be trying to get people to lose weight, but it probably starts to be too little too late because the damage has already happened. And so really, when we don't get healing of joints. So the idea too in all conditions on focusing on weight loss is the idea, well, it can't do any harm. And that's a sort of sounds like a really good idea, but in fact, 50% of people who are obese have described experiencing weight stigma. There is also this idea that repeated failure to lose weight makes people feel a failure and down in the dumps. And, it's not a state secret that that weight contributes to joint pain. In fact, we did a study at the Alfred and found that everybody who turned up at the Alfred with osteoarthritis had tried to lose weight. The other thing that is also very important to know is that it's been shown that more than half of women with obesity have cancelled a medical appointment if they thought they might get weighed. And so this starts to really have this quiet impact on healthcare. Now, we all know it's hard to lose weight. And there's a massive celebration when a person loses weight. You know, we all feel fantastic. Isn't this wonderful? But the majority of people, and it's not everybody, but most people find that the weight just creeps back. And often, very simplistically, we think, oh, well, they've gone back to their old habits, you know, what do you expect, etc. But what's really interesting is that our biology is working against us. So in fact, there's this concept of us having a set point. So my set point is whatever I am at the moment. Each of you will be, you know, whatever you are at the moment. And these set points are determined by genetic and epigenetic factors. Epigenetic factors is a change in the expression of genes based on the environment. So people, for example, that were starving during the Dutch famine in the first trimester, or babies, if there's very, 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 very severe, you know, vomiting and that in the mother in the first trimester, are likely to express genes that make them more likely to be obese later on. Childhood obesity also changes the genes. So what's quite disappointing is that most of our set point of our weight is set in very early life. Now, the end result is that this body set point is defended by our bodies really aggressively. So if you lose weight, all these hormone mechanisms jump into play to get you back to the same weight. And, you know, so people feel very hungry. And in fact, so most of it is driving you back towards your previous weight. And there's been a lot of studies now showing that these hormone changes trying to get you back to your old weight are still there up to 6 years later. So people who have lost weight have to keep working very, very, very hard for years to keep that same weight. You can't even just go back to a normal sort of diet. And there's been evidence that even people that have lost weight with surgery or with drugs or different lifestyle treatments, there's this pushback to go back to your original weight. And what's quite depressing is that as we gain weight, our body set point follows us, and that's sort of, you know, our set point. The reason I'm going through this is because it sort of explains why so many, you know, it's hard to lose weight, but even once you get it off, it's so hard to keep it off. You've got to really keep working hard. Now, there's a lot of excitement with all these new drugs, you know, and these are things like the semaglutide or Ozempic. Now, they have resulted in massive excitement. They suppress hunger. You can lose a lot of weight quite quickly. There is some evidence that if you lose the weight, you'll also reduce some knee pain. There's surprisingly little data, but that's what's emerging. But again, we know that if you lose weight using these drugs, when you stop them, the weight comes back on. They are generally well tolerated. And obviously, if you're obese and diabetic and all the rest, you know, whatever side effects might come with them, you know, like we know lots of drugs have side effects, but so there is the usual nausea, vomiting, etc. But there is a risk of pancreatitis. There is a concern about the amount of muscle loss that might happen and issues with thyroid. And the real long-term safety of these drugs isn't clear, particularly if you decide we're going to give up on worrying about obesity and just, you know, wait till it happens and fixes it. And one of the things that, you know, is getting a lot of interest now just is, you know, this whole notion of Ozempic face and Ozempic breasts, just simply due to the massive amount of loss of fat. And of course, this is, you know, the upshot is that this is now sort of fueling a massive cosmetic industry to fix the problems that have happened. But so are they a good idea? Yes, but they probably aren't going to fix obesity around the world. Now, with, you know, we're talking about musculoskeletal diseases today, but it's the same for diabetes, it's the same for cardiovascular disease. The idea of obesity is a problem, is generally a problem. Now, you could argue that worldwide we're not really winning for any disease, that weight loss is difficult to maintain. The effects of weight loss are modest. The drugs may help a bit more, but you still, there are limits. And so the population, we know, continues to slowly gain weight. And so the question is, are we missing an opportunity? One of the things that I think a lot of people, like often people haven't thought about, is the idea that a lot of weight gain is a fairly steady, relentless gain. Now, there are periods in people's lives where suddenly you can put on a bit of, quite a bit of extra weight, like women after the birth of a child and so on. So there are peak times where people can put on weight. But there's also evidence that through early to midlife, mid-adulthood, there's this sort of 0.5 to 1 kilo a year that happens. And so where people can transition across the different obesity categories. And some recent data from the US, and there's lots of data, but some recent data from the US showed that women between the ages of 40 and 50 gained 5.4 kilos and men 2.6. So one of the things that we don't really do very well is think about stopping that slow kilo creep. Now, it doesn't take long before people are saying, oh, but aren't you just talking about weight loss? I'm not talking about weight loss. I'm talking about the 5 kilos the women will gain in the 10 years. Now, to stop that slow kilo creep, requires low intensity weight related behavior interventions. There's lots of different ones. I don't want to go into detail, but you're also talking about small changes in energy balance of about 30 kilojoules, which is the equivalent of about 4 to 5% of our total intake. And so it requires people, one, to say, I'm going to draw a line under the sand and not gain any more weight, and then keep working on that as a goal. And that can be through eating a little bit less or exercising a bit more, but small amounts. Now, there are lots of trials that show it can be done. And so it's something to think about. Now, I wanted to sort of just show you a little bit of data we had. So we'd seen a number of years ago that people who lost weight had a bit of an effect on their knee pain, but gaining weight over 2 years really was associated with more increase in pain. And, and part of it you can sort of understand, because each of us walks around and our knees are able to cope with whatever our weight is. We've got our muscles and the tendons and everything else. What happens is that if you gain 1 kilo, you load the knee by 4 kilos. So, for example, if you gain 2 kilos, you're suddenly loading the knee by an extra 8 kilos. And so it's probably part of the explanation of why weight gain has quite a magnified effect on developing pain. We showed that a low intensity lifestyle program, which basically kept people's weight similar, wasn't at all focused on joint pains. There was nothing about joint pain in that study. It was done in middle-aged rural women, that really there was a reduction in knee pain in that community. Also, there are potential societal benefits. Now, it's estimated that, if we got rid of obesity and everybody stayed slim, trim, taut, and terrific, we'd remove about 36% of joint replacements in Australia. But what's interesting is, even if we didn't become ambitious and say, let's keep everybody like the green person, but we just got everybody to jump down one category, which means you could the community can still gain weight, but not as much. We have the potential of reducing joint replacements by 20%. And this was data that was based on modeling, and we have found very similar data in a big cohort study. So this idea of preventing people putting as much weight as they might have has potential very big benefits. So I suppose one of the issues is, is it time to think about challenging some of our approaches to obesity? So for obesity related for arthritis and for other chronic diseases, we should be asking people to lose weight. We should, and we do, and most people don't. So if someone can say, well, how are you going to do it? Let's fix it. I'm all for it. And I'm not sure that Ozempic will be the complete answer, as I said. But we find that a lot of people, when we suggest, one, that they try and lose some weight, but also consider drawing a line under the stand and try and make preventing gaining any more weight a goal, people are often quite excited about the potential of something that they may be able to achieve. So with obesity, we do need to try and prevent this slow creep. As people get heavier, we do need to do, weight loss, different forms of diet, exercise to try and get the weight down. For people that are very overweight, then, in the obese category, then often drugs and surgery are needed. So obesity is a major risk factor of osteoarthritis, acting through metabolic inflammatory pathways as well as loading. I think this assumption that we just sort of shut our eyes, ignore obesity and then fix it, particularly, if we're going to now use the new drugs, probably isn't going to work as well as we would hope. And, this whole idea of thinking about slowing this weight creep, getting people aware that it is potentially achievable and worth doing. Because, those ladies that gained 5 kilos in 10 years, even if they gained 2 kilos instead of the 5 kilos, that would be better. There'd be less weight to lose. You improve cardiarthritis and other conditions. And we not infrequently see someone around 48 who turns up with knee pain. They're a bit overweight, just in the borderline between overweight, obese sort of range. And, the recommendations are to lose weight. People go away. Most of the time, people don't lose weight. And that what's quite depressing is that not infrequently that person turns up 10 years later with knee pain and now carrying an extra 5 kilos. I'd like to turn to exercise and really consider some of the very new evidence that's emerging. So late last year, a very nice study came out. Now, this is a meta-analysis where they've taken all the trials and pooled them together. And this a lot of the focus in these studies is knee pain or knee osteoarthritis, because that's just where all the studies have been done. But it still gives you a bit of a proof of concept. And so what happened is that they looked at this and found no clear evidence that therapeutic exercise programs improved knee pain compared to the control populations. And they included all the programs we're aware of, the GLAD program, the different exercise programs, muscle strengthening, and so on. They looked at a subgroup to see is there someone who does benefit, and they found that frail people with high levels of pain seem to have some benefit, but it wasn't in the general knee pain osteoarthritis population. Also, a recent very nice clinical trial done in the States looked at different forms of muscle strengthening and didn't show a benefit. So these results are really saying that we should be encouraging people to do exercise and to go to programs that they find help them help them, okay? But we shouldn't be focusing on pushing people into these structured programs, because many people can't access them, they can't get there, they don't have the time to go to programs. It might be once a week for many weeks. They may not be able to afford it. There might be travel constraints. And the point is that the evidence doesn't show that we should be pushing these programs. Now that sounds, oh my goodness, are you saying we shouldn't do exercise? Exercise is key in arthritis. The key is avoiding physical inactivity. People talk about it being the new smoking. We know that if people are sitting around, you know, lying in bed, within 2 weeks, you lose 20% of your muscle strength. So not doing much has big impacts. We should be encouraging people to keep active. People that are struggling just need to slowly increase their activity. I think we probably should be very careful about making pronouncements like you should do, you know, X number of, you know, hours a week at 10,000 steps or until you sweat or whatever. Those might be goals that might be a good idea, but they can actually act as barriers where if someone's told to do something they feel they can't do or have not a great interest in doing, they just say, oh, well, I might as well sit down and have another donut. So I think we also, for people with pain, we should consider using aids to get people active. So for example, for someone who has some knee pain, then you don't have to use a walking stick. You can use walking poles or a splint, or, you know, a support on the knee and so on. And the beauty of things like the walking poles is they stop people lurching along, you know, because everybody will have seen someone who has a sore right knee. And then the next time you see them a few weeks later and they say, oh, my arthritis is spreading. What's happened is that as they're favoring the right knee and that's getting better, they're putting load on their back or their left ankle, and then that starts to hurt. These walking poles can be very good. And for people that are frailer, they're walking, you know, they're walkers. And, you know, often talk to people and describe them as sort of gym equipment. You know, people don't have to use them all the time, but it's a good way to keep active. So there's no doubt that exercise activity is important for keeping joints healthy. But things like walking and incidental exercise are very good for people across all different, so, you know, different socioeconomic, regional regions where they may not be able to access programs that they might want to do, and to different cultural groups and so on. It's good for mental health, cardiovascular health, and joints. Accessible, effective, low cost. You can do it at your convenience. But what's interesting, it's surprising how many people don't consider it proper exercise, and healthcare workers don't feel that it's proper exercise. But as I showed you, the proper exercise isn't as totally amazing as we all think it is. And so the key about exercise is just to keep doing it. The problem with a lot of the exercise programs is you dress yourself up, get in a taxi, go for a session for X amount of time. But of course, if you can do a bit every day, it ends up being much, much better. Now, what's really neat is some of you may have already come across this very nice Australian study published about 2 weeks ago that actually showed that walking also prevents recurrence of back pain. And so this was, you know, it was largely walking. There was some education, but the focus was on people walking. There was a 30% reduction in recurrence of back pain. The time to getting another episode of back pain was more than 200 days in the walking group and about 112 in the control. So just walking, you know, is a good thing. Now, exercise is good. Exercise is critical for joints. We need to keep people active. We also need to keep thinking about people, the limits of people's activity. So if someone's got a sore knee, you need to keep them slowly increasing their activity within the limits of that pain, maybe using walking poles or something like that, just to take load off the pain. So we don't want people to be thrashed and with a lot of pain, but you often find the joint pain slowly settle. So we need to, so walking, I think, is underestimated. We should avoid barriers. And, you know, Rockefeller, when he was the richest man in the world, you know, 100 years ago or so, you know, was asked how much money is enough. And he said, just a little bit more. And I think that's what we should do with exercise. How much? Just a bit more, and get people just doing a bit more, a bit more, a bit more. Now, I want to turn to this idea that osteoarthritis isn't just one disease and what that means for treatment. So we know that at the knee, it's very much an obesity, metabolically driven inflammation problem. Hip is very driven by the shape of the joint, and hands have a lot of inflammation, hand osteoarthritis. And you say, well, who cares? Well, it does matter, because if we're going to develop treatments, they're going to need to target the underlying mechanism. Now, hand osteoarthritis has quite an impact on health-related quality of life, similar to rheumatoid arthritis. And we all get very excited about rheumatoid arthritis, but in fact, they're very similar impacts. Now, we're taught in medical school that osteoarthritis is not an inflammatory condition, but interestingly, more than 50% of people with osteoarthritis have this inflammation, which we call synovitis, and it is associated with joint damage. This is a joint in 2009, the same joint 4 years later with quite significant joint damage. Now, because this inflammation is associated with pain and joint damage, it's a very attractive treatment target. And in fact, the pharmaceutical industry have tested most of the expensive biologic agents we use for rheumatoid. They cost about $10,000 to $20,000 a year, and disappointingly, they weren't effective. We asked ourselves, what about something simple like methotrexate? Methotrexate is a drug that's been around since about 1980. We use it for rheumatoid arthritis still. Now, you could say, well, why should that work when these exciting new drugs haven't? And the idea was that methotrexate has a broader action. It may not be as good as some of those, but it's got a broader action. Maybe that's why it'll work better. And in fact, we found it did improve pain and stiffness over 6 months at the standard dose we use for rheumatoid arthritis. And the effect of, so methotrexate didn't work as a painkiller. What happens is its action started at about 3 months, and we were still seeing an effect at 6 months. And so it's generally well tolerated and safe, but it has to be used by a doctor. It needs blood tests and so on. But it is the first effective therapy that we have for hand osteoarthritis. So so what now? Lots of rheumatologists are using it, you know, off-label currently. We're keen to still understand, refine the population that might benefit. In fact, in our first study, we actually found that it looks as if women are the group that most respond, which is not surprising, because around the age of 50, there quite a lot of women get what's often been called menopausal osteoarthritis, which is very inflammatory but not rheumatoid. And it may be that that's a sort of population that responds. We need to see if we normally use methotrexate for a long time, so we had to ask ourselves, we had to stop our trial during COVID. So we know it worked for 6 months. So what we're doing is a methotrexate extend, where we're following people up. We're doing an open label study, looking to see whether people benefit for longer than the 6 months and identifying the people most likely to benefit. While we're on the hands, I wanted to just talk about the use of a couple of areas where splints can be very useful for hand symptoms. The first one is the base of the thumb, osteoarthritis at the base of the thumb. As you can see in this picture, there is good evidence that a splint that you can just buy at the chemist for the thumb can be very effective and definitely worth trying. The other one that many people have is carpal tunnel. So people have pain and numbness, often affecting the thumb and just part of the hand. It's often worse at night. There can be pain shooting up the arms and pins and needles. Now, you can certainly go down the route of lots of tests and considering surgery and that, but a lot of people will respond just with a splint that, again, you can buy at the chemist. So as a first pass, you can try the splint. And then, of course, if it doesn't settle, you may need more different treatment. No talk about osteoarthritis is complete without talking about joint replacements. Now, joint replacements are how we treat end-stage osteoarthritis. Now, more than 95% of knee and more than 80% of hip replacements are for osteoarthritis, and they cost us about $2 billion a year. But the key is that the demand is continuing to increase. Now, you could argue, well, if there's a demand, we should just be doing more. I agree. But what is quite depressing about joint replacements is there is no doubt they are fantastic in the right person. But the level of, there's a lot of people unhappy with the results of their knee replacements, 20 to 30%, and about 10 to 20% for hip osteoarthritis, even if they've had no complications and they are technically great. And that is because we should be selecting the people who need a knee replacement better. We shouldn't just be operating because a person has had some knee pain and they have some wear and tear on their x-rays. If you do a knee replacement, joint replacements last about 20 years, and if you need them early, you need it early. But ideally, if you can push it out, so you have them closer towards 70, people are likely to do much better because they cost about so instead of 20,000, they cost about 70,000. But you could argue, well, that's just we have to absorb that. But the results, the outcomes are much poorer. And so, ideally, if you need a knee replacement, have it, but choose the time and do it a little bit later so it sees you out, because a lot of people are now living to their mid to late 80s. So we need to select people well, select people not responding to non-surgical treatment. And it's really important to remember that you can't make someone who's well better just because their x-ray doesn't look very good. The other thing is that I wanted to just say is that osteoarthritis is associated with an increased risk of dying, about 25 to 50% more than the general population. It's not just because people are heavy, people also tending to have more blood pressure and cholesterol problems. So it's a good opportunity, if you've got sore joints and that, to get that sorted out, but also make sure that our heart health is looked at, cholesterol, blood pressure, and so on. So what I'd like to do is summarize about osteoarthritis, that we need to just quietly challenge some of our approaches about obesity and physical activity, consider providing patients with achievable evidence-based goals and approaches. We will need to develop treatments targeting the underlying cause of the different forms of arthritis, and I've given you an example with methotrexate. Joint replacements are fantastic, but people should be selected so that you have the worn out joint and haven't responded to non-surgical treatments. And we do need to remember that we should be targeting cardiovascular risk factors. So having joint pain could be a teachable moment for targeting unmet cardiovascular disease. In the last part, I'd like to turn to gout. And so gout is the arthritis that causes pain and swelling, can cause damage to joints, kidney disease, risk of heart disease. People often need to go to the doctor or emergency department because of a flare of their gout, and it can be a real problem with people that already have heart and kidney disease. We've tended to think of gout as, oh, well, you have sore joints, that's life. But in fact, it's interesting that there's a recent study that showed that people sitting at home minding their own business, you know, doing their usual work, that if you have an acute attack of gout, you're 2.5 times as likely than the general population to have a cardiovascular event in the next 60 days, which is was quite a interesting finding, and that it slowly reduces so that at 6 months it's still 30% higher. And this is thought to be the very acute inflammation that happens as part of gout. And it's interesting, in a typical American fashion, they said, oh, well, maybe every time someone gets an attack of gout, we should be treating the acute flare with anakinra. Anakinra costs $1,500, you know, and it would only treat that flare. It's not going to do anything for the future flares. You know, maybe we should just stop flares, full stop. Now, gout is a funny condition where you know, there is this sort of still this idea that it's all about diet, and if you stopped eating meat and fish and stopped drinking, you'd be okay, that it's all about a disease of affluence, you know, that we just give lots of colchicine and so on. But in fact, it's a disease of buildup of uric acid in the body, and we treat acute flares are where there's this painful hot joint, and there are different treatments that are used, anti-inflammatories, colchicine, cortisone, etc. But then in people that are getting recurrent, you know, more, you know, flare, you know, episode after episode, we need to use medicines to reduce the uric acid. But what's interesting about gout is that when you start lowering uric acid, you can actually cause one of these flares. And so we need people to, you need to sort of slowly increase medicines like the allopurinol, which has been around forever, but also use some preventer. Things like weight loss, avoiding drugs like water tablets, alcohol reduction, diet, have a modest effect. We need to be dropping the uric acid by 30–40% often in many people. These on their own, which can be hard to achieve, only have a modest effect. So they should be used, but they're not going to fix the problem in most people. And again, a reminder that cardiovascular risk factors should be managed. So if someone's got blood pressure and cholesterol, they should be treated. The new thing that's been pushed now is a treat to target. So that if people need to have their uric acid levels reduced, then we need to treat to a target of 0.36. And if a person has AIHWN tophi, which are these accumulations of uric acid, which there are quite a lot of people around with these, then you need to go lower to try and dissolve those. And the idea is to prevent these flares like we saw with that put you at risk of heart disease, that to prevent joint damage, to keep the kidneys in better nick, to stop kidney stones, and also hopefully improve cardiovascular outcomes. And to give you an idea, the allopurinol and febuxostat, which is the drugs that are most commonly used, are very inexpensive, but they've been around for a long time. So everybody's very familiar with their use. And people that should be on gout preventers are if you're getting multiple attacks of gout, if there is a gout with those white lumps, if there's kidney stones due to the uric acid, and some people, there's a few that have just produced a lot. And there's almost no resistant gout. People like to talk about resistant gout, but often it's because it's really hard to motivate people to actually get it under control. And so only 40% of people who probably should are started on gout treatment. Only a minority reach that 0.36. And what tends to happen is that most clinical care for gout is focused on targeting the acute pain, because the pain is so painful that people go to the doctor for that. You almost have to. And so that's where a lot of the focusing care is. But in order to get the uric acid levels okay, you may need 4 to 5 visits in 6 months to a doctor or a rheumatologist. But it's a little bit like treating blood pressure. By the time you're doing this treat to target, people feel well, they're busy, they don't have time to attend appointments, and so it all falls off the radar. There was a study that used a nurse-led approach versus usual care and found that most people using this approach could actually reach their targets for uric acid, and that they were generally better and that it was a great idea. The problem is that people still had to go and see the nurse in the clinic. And so we wondered whether you could adapt this to have a much more simplified telehealth approach, because it's really about keeping patients engaged and compliant. And we tested it out in really complicated, the much more complex patients that we see in a public hospital. And we basically confirmed the person has gout, discussed, what the causes of gout, that it's about focusing on the uric acid. There is this stigma that it's all about excess, that you're indulging, that's why you've got it. So we focused on that. We used a treatment plan using the medication to lower the uric acid. We and then, made sure that they didn't get acute flares. Blood tests were just done at the local pathology. We just called people on the telephone and then traded up the uric acid and then followed them until it had all stabilized and we were able to stop the medicine to prevent flares as well. We found that most, about 3/4 of the people we offered this program to were pretty keen to be part. We got the uric acid down to the sort of levels we would want, and most of it was just with the xylopram or allopurinol, the drug that has been around for the longest, with a few people needing the febuxostat. And so it was convenient, low cost, both in time, no financial cost except making sure you went to pathology. People could just have a mobile phone or landline. It's not, very good, obviously, for people with cognitive impairment, and language barriers can be a problem. And also, if you're concerned about the person's, other health and that, you may need to see them. So the idea of this sort of treat to target approach, preferably done through general practice with a practice nurse, plus or minus some specialist supportive people. Occasionally people are a little bit more complex, but it has the potential, one, to work, but also to sort of get people more clearly understanding that this is a bit like hypertension. You just don't treat it and then it all goes away and you don't have to worry about it anymore. And, there is this idea that gout's probably not quite as great, as an innocuous a disease as many people think. So I'd like to finish off this session really just to highlight that we do need to engage patients and provide treatments that provide feasible and evidence-based and achievable goals. We know there's huge socioeconomic and geographic variation in terms of where services are. A lot end up with the worried well, and there are lots of people that just aren't able to access care. And a lot of the things I've discussed today are actually the better option for, they're not like the poor man's option or whatever. They're sort of keeping people active, preventing weight gain, and so on. They're really where we should be trying to head, as well as all the other approaches that we have available to us. And and it is also important not to focus on things that are probably low value care with modest benefits to patients. And so I wonder whether we should learn from one of the greatest minds of our times that, insanity is doing the something over and over again and expecting different results. Thank you.
Wow, what a fabulous presentation, Flavia. You've covered a lot of ground, and I think given us a lot of some common sense, but really given us an update on the evidence, because I think we're all sick of hearing about weight loss. So yeah, absolutely fantastic. But we do have some questions here, so I'll just ask these questions and see see what you think. With regard to the Lancet meta-analysis, heterogeneity within included articles was large, and I believe there was an overrepresentation of telehealth programs.
Yeah. Yeah. So I think I don't think that we should be panning any method. Okay.
Yep.
So I think those studies, there was a large heterogeneity, which there often is. There were quite a few telehealth and that. But, a lot of the evidence keeps showing that the when there's face-to-face, in fact, UniMelb, Kim Burnell's group, have over and over again showed that telehealth and face-to-face physio end up with the same results. Now, I'm not saying that, a lot of trial information isn't, can bear, it doesn't mean that is religiously how we should follow something. I think that the point is that if you have a patient and they're concerned about their knee, for example, and would like to see someone to get an idea of what they should do and how they should do it and all the rest, they should go to a physio and get advice. I think I think that what's happening with a lot of the trials is just that the natural history is for things to get better. And so it's very hard to show a lot of benefit. The placebo effect almost always in osteoarthritis is huge. So I think that going to Pilates, going to see a physio, for people that would like to do the GLAD program, they should, because people that like to do them, that are able to do them, love them. And, and they're very effective. Lots of people do Pilates. So I'm not for 1 microsecond suggesting don't do that. But all I'm saying is that if you look at the structure of something like GLAD, it's quite time resource intensive. It takes quite a lot of, costs quite a bit for most people and so on. And there's a lot of programs that even if you make them free, people can't get to them because they've got kids at home or trying to do 2 jobs and so on, or can't get to them in rural areas. So really, if you can get to a GLAD program in a rural area, is it a great idea to drive an hour, do a program and drive home? Or would you be better to spend all those hours actually doing some walking? And so I certainly, I think that, so I don't want people to go away thinking should do these, but I think the fact that trials don't show they work, and there is, but recently I think there was a JAMA, Journal of the American Medical Association, just last year doing muscle strengthening, and that was an elegant study. A lot of muscle strengthening, minor muscle strengthening, and nothing, and the results were the same. And that's the same very experienced group that have published tons of trials. Now, that doesn't mean we shouldn't be having people doing exercise and muscle strengthening, but I think going to programs may not be as useful as we think.
Yeah. And sometimes finding, the things that you like to do makes it more sustainable long term.
Well, I think that's right. I mean, I'm just writing a sort of a seminar, about osteoarthritis. And that is so the biggest issue in exercise is compliance is getting people keeping doing them. And in fact, there's work currently being done about the potential contribution of enjoyment, because if you could get people to enjoy it while they're doing it, and they just did it, we'd be doing really well.
Yeah. And I'm a social worker, so sometimes I think social connection has a lot of positive impact. So walking with others makes you go and
Absolutely.
have a few laughs along the way.
I totally agree. They're the sorts of things that people are pushing, walking groups. In fact, they're areas, things we've been trying to sort of quietly encourage, because mental health and feeling depressed and miserable is very strongly associated with musculoskeletal and other pains. And of course, if you can get people walking in a group and generally improve people's mental health and physical, they're compounding things. I suppose the message I was really trying to get across is not to think that, sending people off walking is a poor man's that you only do if you don't live in Metro Melbourne.
Yeah. Yep. No, I think that's pretty clear. We've got another question here, and I won't give you the prelude, but everyone can read it in the Q&A. Would a timely JR be more appropriate versus, waiting to prolong the inevitable whilst overall health deteriorates?
Yeah. So I think that's a very good question, and I was what I was sort of trying to say, but probably didn't say very clearly. So if you're 55 and you're getting joint pain and you're getting a sore knee, okay, and then you've got a terribly sore knee for a few days and you walk using walking poles and the knee settles down, because it often does. Often people have episodes of pain, okay? I would not have a knee replacement, even if the knee looks terrible. So I'm also speaking from personal experience, because a knee replacement will often, so if you just don't settle down, I often think we should be having 3 to 6 month cooling off periods, particularly in private. In the public, it's a, long waiting list. But, a lot of the dissatisfaction is actually surprisingly, if you look in overseas studies, in people that can access them too quickly. So, but I think it becomes different once you're heading towards 70 and you've clearly had a lot of trouble and you still got lots of good days, but it's sort of all a bit tough. That's where it probably isn't a bad idea to go and have it, because if it's going to last for 20 years, it'll probably outlive you. And also, as people get older, they're less active, so their joint replacements are a bit better. Now, we have plenty of people that have them at much younger ages. If the pain is not settling and it's a problem and you've tried, you just have to have a knee replacement. But there is a risk of needing revision. But if you're someone who's done quite well, but clearly going to need one at some stage, I 100% agree. Don't wait till you're, going to have medical problems and then it's worse. So I think that's where some of the, common sense stuff, where I not infrequently see people who say they had no pain when they had their knee replacement. There's a lot of people, they might have an x-ray that looks terrible, but they've got no pain.
No.
know.
And we might just wrap up one little quick question, just to try to get through them all. Given, what you've talked about tonight and the current evidence, should public health hospitals be directing, surgical patients on waiting lists to pre-operative care, such as community rehab, physios, so forth?
Look, they are already. I mean, most of the public hospitals have systems to try and get people. A lot of these messages need to be well before you hit a public hospital. Part of the reason I'm giving these talks is just to get people thinking well before we go anywhere near an orthopedic surgeon or a rheumatologist, you know, trying to sort of change the view that if an x-ray doesn't look great, you have to have a joint, you know, joint replacement, that we have to send people off, you know, for an hour drive to a, you know, an exercise. So, you know, we could do a mixture. You could send someone once or twice for an exercise program to get some advice. Then people do it themselves, you know. So it's really aimed at, you know, once you hit the hospitals or hit a specialist, your fate is sealed.
Oh, well, let's hope not. Flavia, I think we could talk about this for a lot longer, but we've run out of time. But I'd like to really thank you for, you know, sharing your knowledge and wisdom and, yeah, I think support of a lot of patients who, yeah, are struggling with these issues of pain and health. So thank you very much. To let everyone know, this webinar has been recorded and you can view it on the Department of Rural Health, University of Melbourne website shortly. We are likely to have further public lectures this year. And of course, we'll be hosting our Ngāwu Wanyara Aboriginal and Torres Strait Islander Health Conference on October 9, and I hope to see you there. Thanks everyone for attending tonight and have a good evening.
Thank you.